Welcome back, everyone. Might just get started on the afternoon sessions. Our next session is entitled Proving Comprehensive Care at Bathurst Health Service. Our main presenter is Michelle Kemp, who has been a physiotherapist for over 7 years, working across the district through rotational positions. Michelle sits on the Comprehensive Care Committee and works with the committee to look at ways to improve comprehensive care. Also, a main driver in this comprehensive care is Melissa, who won't stand down the front. Melissa Belvante is a manager of primary and community health at Bathurst and is executive support and a real driver in improving comprehensive care at Bathurst. So, in terms of what the presentation's about, in Bathurst, there's been a recent climb in falls. The Comprehensive Care Committee has been investigating ways to improve screening and assessment for risk factors of falls, as well as other hospital-related illnesses and complications. They have selected an emphasis on introducing and implementing comprehensive care bedside plans with individual patients to improve assessment, screening and collaboration amongst multidisciplinary team members. I'd like to welcome Michelle.
Thank you, Ash. And yes, I just want to acknowledge this has been a group effort and definitely would not have been possible what we've done already without the exec endorsement that we've got from Melissa and our executive team. So thank you. And thank you, Ash, as well, who's been providing support to us as well. So thank you very much. So let's put this up. And it was very nicely timed after the last presentation with Marianne and Kate about, yes, our project, our initiative is around comprehensive care to meet Standard 5, which is addressing risks and harms associated with hospital admissions and particular screening for those risks. And for me, that's in around falls. So falls in Bathurst, we've seen a trend from 2022 to 2023. We have seen a climb in our fall rates and total falls. I've just put a little arrow, particularly next to medical, because that is the main ward where I work on, but also you can see there we've actually doubled in the number of falls from one year to the next. So it's definitely a problem on our ward and something we want to address. What we are aiming to do is that we're thinking that with the comprehensive care bedside plan, that it does have the screening tools already encompassed in it, with the FRAMP and strategies around preventing falls, as well as timely was mentioned by Marianne and Kate, other risk factors as well around delirium and malnutrition screening tool assessment items and VTE risk and pharmacy as well. So it does have that comprehensive care component that we hope will help improve not just falls, but a lot of our hospital-associated risks. And the other part as well is that it does also encompass a part for physios to go in, for example, and attach not just the scores that come across from those risk assessment tools, but also sections where we can comment and say what the other risk factors that haven't been captured in those tools are and what strategies we might recommend, which is a really useful thing. I just also want to note that is a really nice way for us to use this bedside plan is that those screening tools actually get auto-populated into our bedside plan. So it does cut down some of the workload, maybe not all the workload, which I will talk about a little bit more in my presentation. So Bathurst launched our implementation of comprehensive care bedside plans mid last year. It was initially piloted in our rehabilitation ward. Our aim was to have formal documentation across wards and disciplines to meet Standard 5 of comprehensive care to screen and address risk of harms, including falls. As well as we did acknowledge that the great thing about it is also partnering with our consumers. The benchmarks that we're aiming for is that we aim for a CCBP to be completed within 72 hours of admission. We aim to have multi-contributors. We want to have that collaborative approach from multiple disciplines. And we want to have the patient carers involved. So we are aiming for that initial bedside plan to be completed, but also it would be lovely as well for us to aim to achieve a bedside plan being completed on any change of circumstance or transfer of care. This would be, for example, for a patient gone from medical to rehab ward, or if there's been a I think I've covered that, sorry, yep. Oh, and weekly after that, follow on. How do we go about it? So it has been a long process. At the very start, it was our exec team endorsing it and then taking it to ward departments and heads, our nurse unit managers, to tell them about the comprehensive care bedside plan, ask them to engage with it, and then taking it to their select areas to implement and endorse it. There was some My Health learning modules that were accessed throughout the hospital for further learning about what they're about. We did make a special emphasis on where it is located in EMR, because that was something that was, even before it started, highlighted as a potential barrier to them being done. And we were aiming to have it implemented by December 2023. This also just coincided nicely with our accreditation, because we wanted to show that we were doing something for our accreditation around Standard 5. The result was that we did just barely pass accreditation because we could speak to this. But what we did find is it's not embedded to our hospital as business as usual, like we had hoped would happen by December 2023. So this is just the start of where I'm at now, and our comprehensive care committee are up to now, where we're now going back to the drawing board, and we're trying to go about finding feedback from the people who have engaged and endorsed the bedside plans, and where we went wrong the first time. So this is just a little bit of a beginner of a brain map of what I've started to collect from different conversations I've had between our nurse unit managers, our nurse educators, our department heads, and physio OTs, allied health, dietitians as well. I've had a lot of conversations with. So I mapped out some potential themes that I thought might be present around barriers. But what I actually found is the list to the right here that seems to come up amongst all disciplines and wards. The first being visibility. So to start with, it is a bit difficult to find in EMR where to actually do a comprehensive care bedside plan. It's labelled a little bit tricky, where it's got a WN at the start and local health district comprehensive care bedside plan. So it does make it difficult if you don't know what you're looking for to go and find it, to complete it. It is also difficult when it is done. The way that it appears in our EMR documentation progress notes is it can look a bit clunky. It's not very friendly to the eye. And it does make it difficult that we wonder if, even if it is being done, how useful is it being integrated into our processes, because it means that we don't believe that people are actually reading it. They're being done, but perhaps it's not read by all disciplines. So, and this also is related to just also that in terms of our systems already in place, we do have our handovers and multidisciplinary team, our case conferences. We've yet to see where this could actually exist amongst those systems without taking place of, and while still encompassing the goals that we hope for it, which is to be by the patient bedside. And this starts to speak to some of our time and resource constraints, that part of the problem with having it at bedside on some of our particular wards, I'll speak about medical, for example. We have 8 consultants who work through our medical ward of 32 beds, and we have a 10:30 MDT round to have everybody involved in their care actually meet at the small space that we have for the bedside would be very problematic. And with the time constraints, so I've seen this when I've spoken to both allied health and nursing staff. One of the difficulties with being able to complete it early on admission is that it is time consuming amongst all the other documentation and assessment tools that the nursing staff have to complete. And for allied health, we do feel that we are documenting a lot of what the comprehensive care bedside plan is related to in terms of patient goals. And we're then having to duplicate it into another format. So trying to problem solve ways around to make that less time consuming. And once again, it is about, if one discipline's doing it, is the other people looking at it. So there is more to be done around the education and awareness space, because as I've spoken to, there is still people who have limited awareness or no awareness. We have a high staff changeover in Bathurst, so we do actually have to go back to basics and roll it out again with just reintroducing and re-engaging people to the bedside plans. But also with the collaboration approach that we hope to have with the bedside plans, the problem I'm finding is that it does take away that element of being able to be accountable for it. So I'm hearing too often that the nurses will say, well, I've started it, but physio won't update it, or I don't know what their mobility status because I couldn't find the physio notes. Whereas the physios will say, well, I went to put my mobility status in it, but it hadn't been started by nursing staff. So we really need that collaborative approach, and we need everybody to be accountable for it to really be embedded as business as usual. The other overall feedback that was quite consensus across many wards and disciplines was that the initial rollout was rushed. So going back and reintroducing it is definitely something that I think we will need to do. How do we know it's not working? Well, another area that I've had conversations with our nurse unit managers and nurse educators is it's coming up as a common theme within complaints that patients are saying that we are not informing them of their patient care, and they feel less empowered to know about their care. And also from our snapshot audits that we've done, we can see that we've got low compliance rate in medical and surgical, but rehab is actually doing quite well. What is working? There is people who are aware of it and acknowledging that they do see the benefit of using it, that it does engage the patient. It does have really good purpose around being collaborative and comprehensive. They see potential for it, but as I mentioned before, it's about, well, are we just ticking a box, or can we actually integrate this into our systems? We can tell that they are being done, although our rates are low, they're just, they aren't being done. And we can see from the rehab ward pilot that it has been implemented and sustained. So what we are hoping to do now is we've actually started another smaller pilot trial in our medical assessment unit, which is a small 5-bed ward, part of our medical ward. We commenced it in January 24. And the reason we chose that ward is it's already a new part of our medical ward that's been set up as an assessment unit. We didn't have a robust system that had a discipline allocated team rounding to that ward. So it was quite a good way to implement the comprehensive care bedside plan. And we round Monday to Friday 9:30 with members from speech, physio, dietetics, and occupational therapy, as well as nursing. What we have found is that's been quite useful in sharing knowledge. So, for instance, listening to how a dietitian might screen a person for malnutrition, I now can recall the questions that would be relevant and beneficial to then see if a nutrition dietetics referral is indicated for a patient. However, it does still is time consuming for all those disciplines to be situated around the bedside when not all members are involved in the care. So what we're now looking at doing is just implementing a rotation system with 2 members at a time doing it on a particular day. And I'm just rushing through because I'm just aware of time. This is a quick snap audit of what I did for a week at random for our medical assessment unit, because I thought if we're concentrating our efforts, I just wanted to see whether that was actually implemented to the area. And you can see there is an improvement in the bedside plans being completed. It's gone from 10 to 31%. We are finding that the documents that are being done are including patients, and they are having co-contributors. So that's quite nice to see. One interesting that I found when I was auditing this is that whilst we are doing them for the majority, the ones that we're actually not doing them for, we're actually identifying as more complex, either discharge planning wise or medical wise, and we're shifting them out of the ward within the 72-hour timeframe that we're aiming to for this unit. So we're not terrible at actually identifying the needs of our patients. It's just once complexity in discharge or medical reasons becomes an issue, we do forget the basics and we do start to focus on other elements. Where to from now? So as I've already alluded to, it is an ongoing process. We're going back to the drawing board. We are developing we're getting feedback from our drivers who are on our wards and our disciplines to find out where we went wrong before. We are getting more leadership on board as well. So we did have our exec endorsers and great encouragement and support from them, but we're re-engaging with our nurse unit managers, our NUMs and our educators, our HODs to redistribute this again. We will be looking at the education again and other possible further PDSA cycles. So one potential area that we've identified is that our communication care boards are not done well. And here's some examples of it. And particularly the one to the right, that's our medical ward care boards. I don't particularly think it's very friendly to our patients or consumers or even to allied health to fill in. It doesn't really give extra space to add comments. So something in the future that we may look to as a direction is looking at how we can better improve on that and implement other ways to better improve communication.